Hi everyone. Well, let's review together the respiratory system, which we covered in the lecture, at least half of it. And this will serve as a reminder for you also when you are reviewing for the test. So the function, of course, for the respiratory system, which we know the respiratory function, is the exchange of gas. The idea is to obtain oxygen and get rid of carbon dioxide. We also learned from biology classes that there is something called cellular respiration. We're not getting into that. But let's agree on the fact that as long as it involves oxygen and carbon dioxide, there will be internal respiration and there will be external respiration. External respiration is the part that takes place in the lung, where you are exchanging your gases by diffusion. Oxygen will get in and carbon dioxide will get out. Internal respiration is what happens at the tissue level, where oxygen will unload from the blood, and instead the blood will be carrying carbon dioxide that was released along with other waste metabolites that are released from that organ. So let's agree on the fact we have internal respiration and external respiration. So this cartoon here you're all familiar with, where the exchange of gas is happening at the lung level and also at the tissue level. And this part here, the circulation, we did cover in great details when we talked about the cardiovascular system. So in addition to the respiration, we spoke at the lecture that we have also other functions, non-respiratory functions for the lung. All of these functions, you will notice them later on as we go into different chapters, like the special sense, they will be aiding in the smell, in activation of some hormones. We will get into angiotensin 2, prostaglandin is also secreted, vitamin D is activated. So quite a bit of things that are not necessarily related to the act of exchange gases that are carried by our respiratory system. They also control the intra-abdominal pressure, they control the release of air from your lungs, so therefore your voice can change louder and softer as you change the amount of air that passes through. The respiratory airways, we're going to just jump through quickly when we are covering that, but we're going to focus more on the lungs instead. The airways starts with the nose or the mouth and then goes to the nasopharynx or oropharynx. From there we'll go to the larynx, and the larynx here we have something covering it, and that would be your glottis that can close and open as you swallow or you are breathing in. And we'll talk about this mechanism fairly quickly when we come to it. Then we have the trachea, and you see that it has almost like a horseshoe kind of a cartilage rings, and then this is the carina, which is the cartilage that is here at the bifurcation of the bronchus, the trachea into right and left bronchus. All of these areas, including the bronchus and the bronchial branches and the bronchioles, there are no exchange of gases happening there. Even at the terminal bronchioles, which are the tiny bronchioles you see here, there are no exchange of gases. But what is interesting and it's important for you to learn is the fact that the terminal bronchioles, which you see here, they don't have cartilage, and instead they will have muscle layers, and those muscle layers, the smooth muscle layers, they are able to control the diameter of those bronchioles, and therefore they can modulate to your airflow and therefore the alveolar ventilation. So we'll cover that in a little bit, but just I wanted you to appreciate the structure which we deal with. And here are the alveoli. These are sacs, and we'll talk about those sacs and what kind of cells are covering. And you will see that they're surrounded by a very luscious anastomosis of capillaries, and that will enforce the exchange to happen fairly easy between the blood and the air that is here in the alveolar space. All right. Here again is your rough anatomy for the lung and the trachea and the bronchi, right and left. And we noticed in the lecture, and we did talk about it briefly, that it is the left bronchus that is more vertical and it's much shorter than the right bronchus, and that leads to aspiration and aspiration pneumonia happening more on the left side, on the right side. This is the right bronchus, I'm sorry, this is the left bronchus or the left lung. The aspiration pneumonia happening more at the right side versus the left side. Alright, so this was a quick review for what we covered at the lecture with the rough anatomy or of the gross anatomy of the lungs and the trachea and the bronchial branches. Again, this is the list for the airway, and we want to focus more on the bronchioles because indeed the bronchioles, they have this characteristic that they don't have any cartilage, and therefore they do regulate the airflow, and that is of course under the regulation of the sympathetic and the parasympathetic system. We will get into that in a very short bit. Okay, so this is what I told you about earlier. That is the glottis, and that's the part in your larynx that closes and opens, and therefore it protects you from aspirating liquid and food while you are breathing. If we get to, again, the bronchioles, I'm going to focus on this, not much on the trachea here. We will notice that there are no cartilage. The wall have smooth muscle layers that are innervated by this, the sympathetic and the parasympathetic system. And they're also sensitive to hormones and local chemicals like prostaglandin and histamine. And we will cover that when we talk a little bit about asthma in a short bit, bronchial asthma. The alveoli, you will see that they are made for diffusion. They have a very thin layer of epithelium, one layer of epithelium, and that we will call type 1 alveolar cells. These are very flattened cells, and it's very important to have it so flattened to allow the exchange of gas to happen very quickly between the blood, which is inside the capillary wall on the other side, and the air, which is inside the alveoli. Well, in addition to type 1 alveolar cells, we have type 2 alveolar cells, which secrete to us the surfactant, and we will get to the surfactant in a short bit. And we have type 3, or what we call the macrophages, and those macrophages, they are like patrol guards. They go back and forth in the cavity of or the lumen of the alveolus or the alveoli to look for targets to attack. Those alveoli are connected to each other by what we call Cohn's pores or pores of Kohn. And the idea is to create communication to prevent the dead space. So even though the bronchioles are sort of clogged or blocked by a mucus or something for some alveoli, still because of these pores of communication that is connecting the alveoli with each other, not all of them, but at least within the same segment, you will see some alveoli are communicating together with those pores. Then you are able to inflate some alveoli even though the leading bronchioles to them are clogged. And that's a very good thing, what we call the collateral ventilation of the alveoli. So here's some cartoon pictures for how the covering of the alveoli look like, and this is the type 1 alveolar cells we talked about earlier, and this is type 2 alveolar cells which secrete to you the surfactant. The macrophages are not necessarily, here is a macrophage, and that is roaming around as we agreed to find something to destroy. You will see that the gap, the distance between the blood, here is a blood capillary, and it's only a single layer of endothelium here lining it. You will see the gap is very, very small, and that is the barrier separating the blood from the alveolar air. The thinner this barrier is, the easier the diffusion of gas. And we agreed also that in some conditions where you have some pulmonary hypertension or pulmonary edema, and this interstitial fluid starts to become very thick, and that will not permit the exchange of gases, and therefore the person is suffering from some kind of hypoxia. Under the microscope, this is necessarily how it looks like with the alveolar space, and here are the alveolar walls. Okay, back to the gross anatomy. The lungs are occupying much of the thoracic cavity. You'll see other things: the heart, the esophagus, thymus, and the big vessels, the aorta, the aortic arch. We will focus on the outer chest wall, not in the anatomy much, but on the physiological aspect of it, because you will see that it's lined up from the interior by the pleura, or the parietal pleura, which is a very thick, dense fibrous tissue attaching itself to the outer chest wall from the inside. And you will see that this pleura flips and covers also the lung, creating an intrapleural space, and that space has very little fluid, and we'll talk about it, the importance of this space and the importance of maintaining negative pressure in that space in a short bit. So the anterior chest wall is attached to muscles, of course, or some muscles attached to it, and those muscles help you with the respiration. The biggest of all is the diaphragm, and we will see pictures and we'll talk more about the diaphragm. But as you remember from the anatomy classes, we also have quite a bit of muscles that aid in the process of respiration, such as the sternocleidomastoid, your scalene muscles, external and internal intercostal muscles, abdominal muscles, the latissimus dorsi. Quite a bit of muscles also help, especially if you have very vigorous breathing. So we will get into that in a short bit. The diaphragm let's see if we have a picture for the diaphragm, and then here's the picture of the diaphragm, and then I will flip back again to the slide. So here's the diaphragm, and you see that it's taking origin from the lower portion here, and the insertion is into sort of a round insertion here, which permits the passage of the esophagus, because the esophagus here penetrates this part, and along with the aorta. And so we also understood from when we were talking about in the lecture about the diaphragm, the fact that when it contracts, it shortens. So instead of being dome-shaped like that, it will sort of decrease the curvature of it, and that will increase the space available inside the lung. And when you increase, not the lung, but in the chest cavity, when you increase the space, you lower the pressure, and therefore you are able to breathe in. We will get into that later on, but let's go back to our slides. The pleural sac, I would like you to spend some time on it, especially on the fact that it's two layers. One of them is lining the thoracic wall from the inside, and the other one is lining the lung, and that creates to us a space in between, and that we call the intrapleural space. Intrapleural space have very little fluid, and that space will always have a negative pressure in it. Negative pressure we are talking about in reference to the atmospheric pressure. A little lower than the atmospheric pressure, we'll call that a negative pressure, usually about 6 below or 4 below. And the reason for the negative pressure, we will get into that in more details, but the fact that the lung is smaller than the chest cavity, and they would like to recoil, and it can't recoil, it can't all collapse, because it's almost like stuck cohesively to the chest wall. So that creates kind of a suction, like with a suction cup. This exactly the same principle of a suction cup on a surface. It will allow this vacuum between the lung and chest wall or between the parietal pleura and the visceral pleura to exist this kind of suction or negative pressure, and that is very, very important to aid in the breathing exercise or the breathing as we will talk about in a very short bit. Okay, if you want to imagine how the pleural sac is, if you would take your hand or lollipop or something and you push it into a water-filled balloon, and you will see that the balloon is forming sort of a sac around that object, and if that is the lung, then you will see that you have here would be what we call the visceral sac, and that would be the parietal sac, and in between you have this kind of space. And we agreed that this space will have a negative pressure. We will talk about that negative pressure. Why is it important in a short bit. Okay, so we need to understand certain things about the physics or the mechanics of the respiration in the lung. The fact that we have three pressures that we always refer to: the atmospheric pressure, which is equivalent to about 760, the intraalveolar pressure, and it depends whether you are in a process of inspiration or expiration, whether the pressure is fluctuating a little bit up or a little bit down. And you will notice that it doesn't take much effort for you to breathe. You just need to drop the pressure by about 1 degree lower than the atmospheric pressure in order for the air to come in. We're talking about normal breathing, not very vigorous breathing. And it doesn't take much either to let the air out. Just a couple of more or one more pressure units, millimeter mercury, to affect this alveolar pressure, and that will allow the air to leave, escape. In addition to these two, which are connected to each other, there is this pressure that is not connected anywhere. It's sort of an isolated picture, isolated pressure, and that will be the intrapleural pressure. And I told you the intrapleural pressure exists between the two layers of the pleura, and it's essentially like the suction cup, the pressure in the space between the suction cup and the glass surface, a mirror or a glass. If we will see that we are referring to pressures not as that they are 760, but you will see us talking about -1, +1, +100, plus this, minus that, which we're really what we're really referring to is the difference between the atmospheric and the alveolar pressure. So a negative pressure would be less than the atmospheric pressure. A positive respiratory pressure will be greater than the atmospheric pressure, and the zero pressure will be equal to that of the atmospheric pressure. It's the same thing, by the way, when we were talking about the cardiovascular system. When we said that the systolic pressure is 120, we meant it's 120 above the atmospheric pressure, of course. Okay, so I'm going to skip through this. We covered it in extensive details at the lecture. If the pressure, which is here, that is negative pressure, and I told you if that is affected, if you lose that negative pressure, then the lung will collapse. So imagine the negative pressure that is holding the suction cup to a glass surface. If you go inside that suction cup and inject some air, you will lose that negative pressure, and therefore you will be able to remove the suction cup away from the glass. And exactly the same thing happen if I would allow air or liquid, blood, effusion to become in that pleural sac. Therefore, I'm losing the negativity of the intrapleural pressure. We agreed that this will cause lung collapse, or what we call atelectasis or atelectasis, and that is the collapse of the lung. You don't want to have that. So we talked about it in great details. What happens when you have an open wound and that affects this the negative pressure you're supposed to have, and especially if you start building up blood or other things inside the pleural sac, then of course it can be a fatal condition. So what maintains, again, the intrapleural pressure to be negative or subatmospheric. The fact that the two pleura have this cohesiveness between each other because it's not much fluid there. So again, I'll come back to the example of the suction cup. If you put too much water under the suction cup, there won't be any negative pressure there, but the fact is that you are pressing the suction cup so down, you're getting rid of almost all the air or all the water, so the distance can be very, very little. If you translate this example into what we have in the pleura, if you increase that space, of course you lose the suction or the negativity between the two layers of the pleura. That is one, and then I told you that the lungs are generally smaller than your chest cavity, so it would rather shrink. It would rather pull down to a smaller size, but that is not allowed to happen because the lungs will be sort of stuck on the chest wall from the inside because of the suction that is maintained by the negative pressure in the alveolar or the cohesiveness between the visceral and the parietal pleura, and therefore you are not allowing the lung to collapse. But by not allowing the lung to collapse, you are pulling more and more on your suction cup, and so the pressure under the suction cup, which is in our case the pleura, will be always negative pressure, right? And we did cover that when we talked about the lecture. And in case if someone gets an open wound, then unfortunately, whether it's from the outside or from the inside, then the pressure here will be equalized, and that of course will create a problem. Whether the air is coming from inside or from outside, that can cause one of the lungs or both lungs to collapse as a consequence. Okay, so any change in the alveolar pressure will produce flow of air. If you would increase the alveolar pressure, then the air would rather go out, unless you're closing it, like with the glottis when you're coughing or when you're straining. You're not allowing the air to leave your lungs, but in normal situation you are allowing the air to leave the lungs, and that is all maintained by just a slight variation of the pressure inside the alveoli. A very small variation up and down will allow the air to escape, and that is a very good thing, and it's really maintained by this kind of negative pressure that we saw in the parietal in the pleural space and the intrapleural space. As I told you before, imagine if someone is lifting the weight for you 99%. So all what you need to do is lift 1%, and then you will be able to lift that weight off the ground. So imagine if there is someone for you, which is in this case the cohesiveness of the two pleura against each other, and the fact that they are pulling on the lung, 99% of the work is already done for you, and all you need is just to give a little bit of extra effort to inflate your lung. So it's no wonder that the lung is almost half full all the time. Not half full, but it's not all empty all the time because of the nature that we just talked about, the suction cup effect that you have inside the pleural cavity that keeps the lungs pulled towards the chest cavity. Okay, so if the pressure inside the alveoli is less than the atmospheric pressure, the air will enter in, and the opposite is indeed true. This is a little thing explaining to us the Boyle law, which is this is the atmosphere. At atmospheric pressure, we have a certain volume of gas, and if we reduce the same amount, if we reduce the volume of the gas by pressing with a piston or something, then we know that the pressure is increasing, and the opposite is true. So it's the same thing in the lung. If I would increase the space inside the chest cavity, then I am reducing the pressure. right? Just like here, I increased the space for the same amount of air, then I reduced the pressure, and if you reduce the pressure, then that will allow the air to come in. And the opposite is true. If you increase the pressure, if you reduce the space, then you're increasing the pressure, okay? So back to the muscles, and we did talk about that we touched on that earlier, but I'm going to refer to it again. We have the diaphragm. That's a very important muscle that's innervated by the phrenic nerve, which is coming all the way from your cervical plexus. And if anything happened to that, then of course, then, or the cervical, the spinal nerves from the cervical region, if anything happens to the phrenic nerve, then of course you lose the ability to breathe in and out. In addition to the diaphragm, we have other muscles, the external intercostal muscles. That's also helping for the inspiration. And if you need additional effort, then you will be helped by what we call accessory inspiratory muscles, such as the scalene and the sternocleidomastoid muscles, which will also assist you in opening up your chest cavity, and therefore increasing the area in your chest, and allowing the negative pressure to be even higher against the lung and the intrapleural space, and therefore it's easier for you to breathe a larger amount of air. We sort of covered that, and I told you already about the accessory inspiratory muscles, and you can have a picture of it here. The internal intercostal, that's an expiratory muscle. The external intercostal, that will be inspiratory muscle, and we have the sternocleidomastoid and the scalene. Additional expiratory muscles will be the abdominal muscles, the rectus, the external oblique, and the internal oblique. All of these guys can help you with your respiratory movement, but they are not needed for it. The only one that is definitely needed is the diaphragm, and the expiration is a passive phenomena. You don't need any muscles to give you the passive expiration. The amount of air that you're breathing out with a regular breathing exercise, that's a passive thing. The minute the diaphragm relaxes, then the space here in the thorax gets smaller. The thoracic cavity gets smaller, and if it gets smaller, then it allows the pressure to build up inside here, and if the pressure increases, then the air will just leave. Okay. So the onset of the expiration will start with the relaxation of the inspiratory muscles, which is mainly the diaphragm. And as we agreed that the pressure, when the diaphragm pulls down, it will reduce the pressure inside the thorax, and that will translate into the pressure inside the alveoli being negative, and that will draw the air in. And the opposite is true. When the diaphragm relaxes, it will pop up again, and that will reduce the volume and inside your chest, and therefore increase the pressure inside the chest. That will translate to increasing the pressure inside the alveoli passively, and therefore the air will leave. Okay. So the differences we're talking about are not really great. I mean, we have the atmospheric pressure here being 760. If you are breathing in, all what you're doing is reducing it by 1 degree, and that will allow the air to rush in. And the opposite is true. If during expiration you increase it just the normal expiration, we're not talking about the very strong expiration, as you will learn more about it in the short slides to come. And that will allow the air to just flow in and out. And so you will realize that the lung is a perfect system through which you're already halfway helped by the fact that you have always negative pressure here pulling on the lung. So all what you do is just to exert a little bit more of negative pressure, and that will draw the air in, and you don't even have to make any effort to let the air out. So The process of respiration is not taking a lot of your energy, which is really good, because you're breathing all day at a regular level, not if you're breathing heavily, of course. That will increase substantially the amount of energy that you need. Again, it's a small cartoon here to show you what happens when you're breathing in and out, and I want you to always realize that the intrapleural pressure is always remaining negative. It's a closed space. It's not connected to the alveolar air. It's not connected to the atmospheric pressure unless someone gets stabbed or connects somehow the inside of between the pleura to the outside. But that is a serious situation, as we all agreed and we discussed in the lecture. This is a different cartoon, and it's pretty much explains the same idea we talked about. The flow of air, in addition to the change of pressure, will be very related to the radius of the bronchioles and the radius of the airway passage, the airway that the air has to pass through. And just similar to the facts that we learned from the cardiovascular system, if you change the radius of the blood vessels, then you are increasing the resistance, and therefore you are not allowing the flow to occur as much. Exactly the same thing happen when we are dealing with the lung. If it's excessive enough to obstruct the ability of the air to efficiently ventilate your lung, then we are dealing with diseases, and we call that chronic obstructive lung disease or chronic obstructive pulmonary disease. And in chronic obstructive pulmonary disease, it's exceptionally hard for the air to go through, whether that's because of an inflammatory process such as in chronic bronchitis, or due to the fact that the muscles, the smooth muscles surrounding the bronchioles, are becoming tighter for one reason or the other, whether it's histamine release or prostaglandin or something happened there that made the smooth muscles constrict further, and usually it's driven by allergic reaction, or emphysema, which is a situation, a very serious situation, where your own lung tissue being consumed by digestive enzymes that are present, and in general situations you're supposed to neutralize those digestion enzymes, but that doesn't happen. So in emphysema you will see a lot of loss of lung tissues, but at the same time, in addition to the loss of lung tissues, you also have the air passage being much tighter and the bronchioles being much tighter than they should be. So again, in emphysema, you don't have to remember this, since this is not a pathology or clinical class, but there is a collapse of the small airways, and you will see in the next slide that the alveolar walls are also collapsed down, and those proteolytic enzymes, they chew off the lung tissues. If you look under the microscope, if you take a section of the lung, this is how it generally should look like, and then you will see here that it is really the lung tissue is collapsing. This is here a situation where someone has a pneumonia, and you see that there is a thickening of the extracellular space, and that of course does not allow easy exchange between the blood here in the capillaries and the alveolar, the sac, and the alveolar, the air. So this is all what we had before, is just talking about the structures of the lung, whether it's microanatomy structure, the histological structures, and the relation between that with the functions of the lung, what happens when you breathe in, why does the pressure drops, the importance of having the pleura, the importance of having this negative pressure inside the pleural sac, which we compare to the suction cup that is holding the lung almost cohesively against the chest cavity, and the importance of this. So every time when you're breathing in, you're not starting from a collapsed lung, you're starting from almost inflated lung, so it's much easier for the gas exchange to happen at this case. But here now we talk about things inside within the lung, factors or within the lung itself. So if you imagine the resistance when you are blowing a balloon, this what we call compliance. It's the ability of the lung to be stretched. How much effort do you need? If it's a very thick balloon, you will need quite a bit of effort to stretch that balloon. If it's a thin balloon, it's much easier. So it's exactly the same thing we have in the lung. If the lung becomes thickened somehow because of fibrosis or because of inflammatory conditions or something, then it becomes much harder to inflate it in and out. So the part that becomes affected here is the compliance. The compliance can be also affected by the fact that the pleura become thickened. If you had repeated infections there, then the pleura is thickened. And imagine if you have like sort of metal cage surrounding your lungs, so now you're breathing not much easier than without all this pressure applied on your lungs. So it's like someone holding your chest and at the same time you are asked to breathe. So it's not all the time you have factors from within the lung that is affecting the compliance. Sometimes you have also other factors affecting the compliance as well. The other thing we want to talk about is the elastic recoil. Why does the lung empty? The tendency of the lung to empty, the tendency of the lung to rebound back after it has been stretched or inflated. And that's maintained by a protein called elastin. We did talk about that earlier on in our chapters. And that will be responsible for the lungs returning back to their original volume. The elastic recoil will be depending on two factors. One of them is the elastic connective tissue, which is called elastin, and the other one is alveolar surface tension. As I told you before, the alveoli are covered with a very thin layer of water, and we all know that water likes to stick together because of the hydrogen bonds. That's why when you make a drop of water, it makes almost a sphere-like droplet. And if it's left to the alveolar surface tension, the lung wouldn't like to inflate because the water doesn't want to be stretched. The water would rather hold on together. So in order for us to lower that surface tension, we put something called surfactant. These are a group of chemicals that they will reduce the surface tension of the alveoli, and therefore allowing the lungs to be stretched without any effort. So we have situations where we don't have this surfactant, like in newborns, preemies in particular. They haven't developed yet the surfactant, and therefore they have problems inflating the lung. The lungs would rather collapse than to remain inflated, and that's because of the very high surface tension inside the alveolar sac, and again because the water likes to stick together. So thanks to advances in medicine, of course, now we have synthetic surfactant that we give to those babies, and that is a lifesaver now. Previously they used to be put on respiratory machines. Okay, we did cover those two things, and we did cover the fact about the surface tension and the surfactant. What we need to also realize about the surfactant is the fact it's much more important for the smaller alveoli, because the smaller the alveoli, the higher the surface tension will be, and that is the part where you want to disrupt most. And the bigger the alveoli is, the lesser surface tension is. And so what the surfactant does is sort of making it equal for you to inflate the small alveoli equal to that of the large alveoli. And so it's important to distribute the air and making it much easier for you to breathe in and out. Okay. We did talk about the premature infants and what happens, and the fact that it affects 30,000 to 50,000 in the US, and that's because, of course, they don't have the surfactant yet. Okay, so let's talk now a little bit about the work you perform in breathing. As I told you, someone already did 90% of the work by holding the lungs for you semi-inflated, and that is carried out by the suction you have between the two pleural sacs that keep the lung always in a semi-inflated situation. So for that you need very little amount of your total energy, about 3% or so, and we also discussed that the fact normally operates at half full capacity, and if anything goes wrong with the lung, for the things we did cover before, then the work of breathing is increased. So whether the compliance is decreased, so it means that you need now more effort and more pressure to inflate your lungs. If that happens, then of course you need more energy. Or if the resistance has increased, and if you increase the resistance, the airway resistance, mainly the bronchioles, if you close the bronchioles, then it becomes very hard for you to breathe, and therefore you will need to exert extra effort. Imagine if you are deflating a balloon, and if you allow the balloon to deflate on itself, then yeah, that's easy. But if you sort of close the opening of the balloon, it will take much longer time for the balloon to empty, and that's the time when you grab the balloon and squeeze it to force the air inside. So you will exert extra energy, you will spend extra energy in order for you to deflate the balloon. And that's exactly what happened in the lung. In the lungs, if the airways get clogged. Very rarely we have any effect happening with the elastic recoil. If the surface tension is changed, that will affect your pulmonary compliance, of course, as we said earlier. And one more thing, but that's physiological. If you are running or if you are doing some exercise that demands more oxygen, then you will see that you are breathing heavier, of course, but that is as a reflex, and that's of course will increase perhaps about 15 times, or not 15, maybe 10 times the energy that you are spending just to obtain the oxygen. Okay, the volumes of the lung during respiration, we did cover that at the lecture. This I would like you to remember, and I think I have a better slide here for these volumes. This is made by something called a spirometer, which essentially measures the drum, a drum that's on a surface of water or electronic, goes up and down. That will be connected to a needle that goes on reporting papers. So when you're breathing in, the curve will go down, and if you're breathing out, the curve will go up. This is what you're looking at. If you're breathing in and out the regular amount of air, we will call that the tidal volume, and the tidal volume is fairly small, about 500 ml or so, and that gets mixed up with the existing volume that you have, and we will talk about the dead volume in a very short bit. That includes the dead volume, by the way. If you breathe in heavily, if you force yourself to take in more air to the maximum amount that your lungs can allow, that will be called inspiratory reserve volume. This part here, which is in darker blue shade, that would be your inspiratory reserve volume. If I would add the amount of air that you generally would breathe in, add that to the inspiratory reserve volume, if you add the two together, we'll have a name for that. It's called inspiratory capacity. This is the total amount of air you can inhale in. The opposite is true. If this is the total amount that you can breathe out during normal breathing or expiration, and this is the amount that you can force out of your lung, if I add this, which is called expiratory reserve volume, plus the tidal volume, we actually don't have a name for them together, so you can just ignore the fact that I mentioned that. But this part here, which is the amount of air that you are expiring or expelling out of your lung, not with the regular breathing, but after it's over, after the regular expiration is over, then you are squeezing out the rest of the air in your lung, and we will call that expiratory reserve volume. What you will notice here also, the fact that you always have something left inside the lung, and the lung is never flat. You can't flatten the lung unless it's completely collapsed because of some reason, and that we will call the residual volume, which is not little. It's 1200 ml, which means every time you're breathing in, especially with regular conditions like here, this 500 ml will get, mixed up with everything you have inside the lung. So that sort of changes the parameters quite a bit, and dilutes your oxygen with the existing air you had inside the lungs left, and then when you are expelling that out and then you get fresh air, that again gets sort of diluted in that air that you have here left, which is the functional residual capacity. And so what you will notice is the fact that your gas concentration inside your lung doesn't change much when you're breathing in and out. It's actually sort of kept constant, and we will talk about that and how important that is for the gas exchange process to happen with your blood. Because we all know that your heartbeats have nothing to do with your breathing in and out. So if you would think that you will only have oxygen if you are breathing in, you're mistaken. It's actually you're getting the oxygen all the time from your lungs, whether you're breathing in or out. And the opposite is true for carbon dioxide. You are exchanging carbon dioxide outside your blood to the alveolar sac, whether you're breathing or not. What you're doing with your breathing, however, is that you're replenishing that air. You keep adding fresh air to make sure that there is no accumulation of carbon dioxide, to bring in fresh oxygen all the time to the lungs. That's why you can hold your breath for quite a bit of time without turning blue, because you still have some oxygen in your lungs, and until that oxygen in your lungs get depleted, then you start to demonstrate some cyanosis or something because of the depletion of that lung. So this is a very important thing to notice about the respiratory movement, and those things, those labels here we mentioned, they're very important for pulmonologists when they are looking for how compliant is the lung. Do they operate or they don't operate? Is there extensive fibrosis with the COPD? Does the person require a transplant, or he can wait a little bit? So these things can help them in determining the severity of the disease. In addition, of course, when they measure the oxygen in the blood and the carbon dioxide in the blood, that helps them quite a bit in what we call the lung function tests. Okay, but one of the lung function tests is what we see here, because it gives them an insight not just about the exchange of gas, but about the mechanics of the lung. Is it inflating? Is it not inflating? Does it have a resistance? Is the elastic recoil affected? Is the compliance affected? And so would like you to remember this this graph, and the fact that we have the tidal volume. If you add a little more to it, then it becomes the inspiratory capacity of the lung, and that would be the opposite of that would be the expiratory reserve volume here, which is the amount of air that you're able to bring in addition to kick out of the lung, in addition to the amount you kicked out already by the normal expiration. That will be the expiratory reserve volume. If I would add all the air that I'm kicking in and out, that will be called vital capacity. If I would add also the amount of air that you are not able to get rid of, and we will call that the total lung capacity. Just remember one more time, just because the fact that you are not getting rid of this 1200 ml, it doesn't mean that those 1200 mLs are unreachable. No, you are exchanging gas with these guys, and when you are bringing in, so imagine if you are bringing in just 500 ml, that 500 ml will mix up with approximately 2.5 liters of air already existing in your lung, and so on and so on and so on. So that's a very important concept to keep in your mind, that you're not emptying your lungs, and therefore the pressure of oxygen inside your lung, and we will talk about that in a short bit in this lecture. The pressure of oxygen and the pressure of carbon dioxide do not fluctuate much, and the exchange of gas happens all the time in your lung. Okay, so things can happen wrong, and what we call respiratory dysfunction, and it can be due to destruction of the lung tissue or restrictive lung disease. Restrictive, it means anything that does not allow the lungs to have enough compliance. And those, of course, will affect negatively, will impact negatively the spirogram that we looked at, whether the problem is that the lung is restricted or the fact that you have now an obstruction and it will take you much longer time to empty your lung. You will see the time needed even for the tidal volume to occur is much longer, and here for this inspiratory reserve to occur is also much prolonged. So you will also notice that the inspiratory reserve volume, the expiratory reserve volume becomes significantly reduced. And in other words, you will see in COPD patients that the lung is overinflated because you are unable to get rid of much of the air, and therefore the residual volume is much higher. You don't have to know this, but you see how those volumes can help you determining what the patient is suffering from, because the patient can suffer from deoxygenation of the blood. You don't have enough oxygen, and the reason for it can be obstruction or the fact that you have something that restricts the movements of the lung. Just by looking at the different curves and how they change with the spirogram changes between those two patients, it can indeed help you determining what the patient has. Okay, so I'm going to take a break here, and we will cover together in the second part of this chapter the very important mechanics of exchange of gas, and the loading and unloading, and also about the pulmonary ventilation and the alveolar ventilation in the second part of this lecture. So let's take a small break, and please join me for the second part of this video.